afternoon. I am Jana Broughton with Superior Health Quality Alliance, and joining me today is Jessica Henkel and Patty Leonard, and also joining us in just a few minutes, it will be Amy Magner. So we will go ahead and turn it over to Patty. Patty, was there anything that we needed to cover before we started from last week? Any follow-up questions?
Yes, we do. We had a question about yeast treatments, about fungal rashes. So I tried to do some online research, as I'm sure many of you know that there's just really nothing out there, but several of us put our heads together and we kind of come up with some general guidelines, which I will put into chat a little bit later for you. But our recommendations for you would be to basically look at your process, try and come up with a procedure, an algorithm, check to see that your residents are getting bathed and showered regularly, and that the areas under the breast, between the toes, all those areas that you're worried about getting those little rashes or redness are getting thoroughly dried. Some education on appearance of rashes and what really yeast rashes look like, because not all the rashes, sometimes they just have a heat rash or an irritation. And look at what your products are. Most places have an agreement with a company that have a whole range of skincare products. Is there a barrier cream that would work for your residents? I know we used to use barrier creams. We used Inner Dry, and then there's some powders out there. Check and see what kind of products would work best for your residents. And then look at the rest of your process. We ran into trouble at my building when the nurses were the ones that were going with standing orders and were ordering a lot of mycostatin powder and creams without really understanding that it wasn't always necessary. So do you want to put a process in place where these rashes need to be evaluated by a provider before you get the antifungal ordered? So just look at your process, perhaps put in place an order set, an algorithm, but definitely I would recommend some education. If anybody else has any ideas that they want to put in the chat, that would be great. We're all here to learn from each other.
Then Patty, Jessica just reminded me, we had a little bit from last week to cover. You're going to go back to those slides and start from there, correct or no? We'll do that at the end.
I didn't have them pulled up. I think the material was more general in nature, so I'll try and make sure that I cover it this week and next. So today our focus on our week 5 is with vaccinations and staff competency. So that would be F883, 887, and then 945. With the objectives being, as I stated, to review the requirements for those vaccine tags, look at record keeping especially, and then Amy's going to talk about the requirements for infection education and training. So we have a quiz. Jana, do you have?
Are you going to go ahead and share your slides, and then I will?
Yes, I guess I should do that. Thank you.
I'll load the quiz, and we have an attendee with their hand raised.
Yeah, that I'm not sharing, so hang on here.
Okay. So the quiz that Patty wanted us to put up was, which of the following statements is true about administering vaccines in a long-term care facility? And you guys did very, very well. The facility must educate residents about vaccinations. So we'll put that and share that one. Yes. All right, Patty.
All right. So now I have my screen up, so thank you. So these are what the F tags really say, and the wording for whether or not it's a influenza or pneumonia vaccines is very much the same. It says the nursing home must develop and implement policies and procedures, the goal to ensure that residents receive education about these vaccines and that the vaccines are offered to all those who wish to receive them. The difference being with the COVID vaccine, the F887 tag also requires that staff receive the education. And there's some source documents at the bottom there for you. And then in just a little bit more discussion.
Sorry, we're not seeing your slides. You didn't share your slides.
You're still not seeing? Okay.
We're not seeing them. I'm sorry.
No, fine.
I can share if you'd like. We can do that.
Yeah, I guess you're going to have to, because when I click on share, nothing. Well, hang on here. Are they up now?
Yep, we see them.
Okay.
Thank you.
I do apologize. I always say old nurses aren't the best for technical issues here. So the policies and procedures, you need to understand that residents can refuse the vaccines, and sometimes there's contraindications. But the big key on this one is the documentation. When the surveyors are come in, they're going to want to know that it was documented, that they were ineligible, for example, if they had an allergy or they've refused, and you need to be able to produce that material pretty quick. If you have to go really digging for it, the surveyors are going to start questioning your process. As well as with the COVID-19 vaccines, you have to be able to show that the staff has had education and that you're not necessarily required to provide the vaccine, but you have to give them information on where to get it, whether or not, there's a clinic at the local Rite Aid or the health department. And I know with the closing of some of the pharmacies in some of the areas that it's really limited the number of places, but generally Walmart has them for sure. So we have another quiz here. How often are long-term care facilities required? How often are you required to offer the vaccines? Only as needed, every 6 months, on admission annually with new vaccine recommendations, or when the medical director tells you to. 100% at admission annually and with new vaccine recommendations. And especially with the COVID vaccine, they kind of threw a unexpected requirement in there last year when they wanted to offer all the seniors an additional dose. So we have to be able to make sure that you keep up on all those requirements. So the best practice would be to build an immunization program, that you have those policies and procedures in place, that they're reviewed, your medical director has input on them, your human resources department. It should be more than just the infection preventionist writing them. For your residents, make sure you're checking on admission what vaccines they need. Definitely you're required to offer the influenza, pneumococcal, and COVID-19 vaccines. Make sure you have orders from the physician for them, and that you're documenting that administration, and that you're tracking who's got them, who's waiting for them, and that you can, like I mentioned before, being able to prove that documentation and that the education has been required. And then the compliance with the staff vaccine requirements, keep that information as well. It should be kept in a private place, not in your office, in your human resources records, all locked up so no one else, that's all private information. The regulations for your immunizations are the tags F884 to F88. Now, if you go looking in the state operations manual, you will not find them though. They remain in the QSO documents, and I linked them here for you, and I did check the links this morning. I will say that the F886 has expired, but we still left it on the slides in case you wanted to look at it. Citations for the F83 and F887. This was from a couple months ago, but as you can see, all the three of the states are getting them generally at a D or E level, so not too serious. It's not that we haven't seen IJs for vaccine, but generally I would say they're at a lower level. But the findings include resident consented to get a vaccine, and when they looked through, they couldn't prove that it had ever been given. The wrong representative had signed the consent forms that were incomplete, failure to offer annually or with the changes, as well as failure to get orders, failure to document the administration. So basically, the survey findings, if you have a loose process, you don't have a good procedure, you're not tracking well, it can get you in trouble. And if you get an F880 and an F887, generally you're going to get a directed plan of correction, for which we will help you with that if you reach out to us. These are other citations. If you don't document, you need to give either the VIS or the package insert for the COVID vaccine, and check your registry on your admissions, as we mentioned, to make sure that residents haven't got a duplicate vaccine, because I've actually seen the citation given for that as well. So again, we mentioned maintaining your records. And that would probably be the best tip that we can give you for compliance, is solidifying your process, making sure that your education is given to absolutely every staff person and every resident, no exceptions. The surveyor, that'll be the one that they'll pull and they'll find. Now, this sometimes comes up that hospice will refuse the vaccines. It's not up to hospice. They're not your physician of record in your facility. So make sure that you aren't allowing that practice in your facility. And here's some more compliance tips that we came up to, the making sure that your policies and procedures are changed as needed and that they're based on the current guidance. We do recommend one person coordinate the program and oversees the record keeping, checking your admission, immunization records, as well as incorporating the vaccines into your new hire process right now. Definitely look at, you should have had an agreement for your flu vaccines now. A lot of facilities that we're talking to are in the middle of their flu clinics right now, and they're also offering COVID that can be given together. And we had the bullet here to make sure that you have and know where you're going to get your vaccines all the time. And your vaccine program should be part of your facility assessment as well. Consider tracking your vaccines on a log. Most places have an Excel spreadsheet. If you use point-click care, obviously you can print reports out of there as long as you're entering it into your immunization records. And this is actually a pretty good best practices checklist resource that's linked at the bottom of the slide here as well. Here's an audit. This would be your critical element pathway that CMS uses for your survey. Do some random chart audits, especially if you're in your survey window, to make sure that all the documentation is there, that you're not missing anything. I would have someone, audit your employee records as well. And when you identify your gaps, you need to do a root cause analysis as best practice and put it through your copy and put a process in place that will get you by your gaps so that you won't have issues going forward. And if you haven't looked at your entrance conference worksheet for when you have survey, number 29, they want you to provide your influenza, pneumococcal, and COVID-19 immunization policies and procedures. So most DONs have a binder with all these materials ready to go. So when the survey team arrives for your survey, you can just present the binder to them and it has all the requested material there for them. And if you weren't aware, based off of the MDS, there are measures for quality based off of immunizations, and they're based off of short stay and long stay residents. And these wording here on the slide is exactly how it reads. The percentage of short stay residents who needed and received a flu shot for the current flu season, the percentage of healthcare personnel who got a flu shot, percentage of long stay residents who needed and received a flu shot, and the percentage of long stay residents who needed and received a pneumonia vaccine. And pneumonia vaccines have got a little bit trickier too. So make sure that you're not going to get caught up on not being up to date on that. And these are quality measures that are publicly reported. So make sure that you're auditing them and looking at what those, because the surveyors know this information before they arrive at your facility as well. So before we go on to staff competency, are there any questions about immunizations? If not, we'll pass it off to Amy. Amy, do you want me to move your slides for you, or?
Yes, please. Could you do that for me, Patty?
Yeah, be happy to.
Great. Thank you. I appreciate it. Okay, so I'm going to talk a little bit about staff competency today. So each facility must have sufficient clinical and support staff with the appropriate competencies and skill sets to provide care, especially clinical care, and then related services to assure staff and resident safety and to attain or maintain the highest practical physical, mental, and psychosocial well-being for each resident.
We have the quiz up right now, Amy.
The quiz is not for another 2 slides.
Oh, okay.
Sorry. But you can take it if you want while it's up. It's fine.
Yeah. Select the statement that correctly describes the differences between competencies and compliance. Competency and compliance are the same.
So to understand a competency, it is a set of knowledge and skills and abilities, also known as the KSA model. So some of you may have heard it as the KSA model. I'm going to talk a little bit more about that in just a few slides. But competency is needed for every person to successfully perform various job duties. So as an IP, your staff competency assessment should include your frontline assessment. So you want to make sure you're evaluating your staff's behavioral, technical, and resident-based competencies, as well as managing and assessing your staff's ability to perform those tasks. And then competency should be evaluated for all levels. So that includes novice nurses, advanced beginners, competent. So when I say competent, I'm meaning those staff who recognize patterns of clinical situations and can respond quickly and more accurately than maybe a beginner. And then as well as your proficient and expert levels. Next slide, please.
I think I already moved for you.
We did quiz 3. You did.
Yeah, okay.
So we're on to slide 19. This should be understanding competency. You should go back one. Yeah, perfect, right there.
Okay.
Yep, that's it. So when we talk about competencies, you have to really have a good understanding of what does competency mean. As I stated, they're not only about what an employee knows, but it's how they apply what they know. Competency means being able to perform a specific skill or task safely, efficiently, and correctly. And then they should actually be defined in your expectations for each team member's responsibilities, depending which department they work in. Your competency should be observable and measurable, meaning when we say observable, you are able to actually visualize, see that person actually performing the task, and they understand how to carry out that skill correctly. And then measurable, meaning the person also understands how to apply the education and training they have been provided to meet the desired outcomes in the care that they are delivering to your residents. There are multiple different types of competencies. However, I'm going to focus on 3 primary competencies that I really would like for, especially as an IP, to focus on. And the first one is core competencies. And core competencies are actually the qualities, knowledge, and abilities required for employees to perform a skill or task at their best. So this is very specific to each individual. They define what makes an employee unique and irreplaceable. Core competencies is actually the ability to practice a skill that meets the needs of resident care for using logical thinking, as well as accurate skills within the employee's skill set. And they're actually individualized. And then one thing I want to clarify about competencies, that they are closely related to skills, but they're not identical. Often you will hear skills and competencies used interchangeably, and they're actually not. So a skill is the task itself, and then the competency is actually being able to perform that skill safely and correctly. The second competency that I just want to touch base on just briefly is the organization-wide core competencies. And so when we talk about the organization competencies that you want to focus on, these are the competencies that are essential for all employees. They are core capabilities selected to achieve an organization's strategic objectives and the skills and their abilities that allow an organization to be successful in achieving its goals. So with organization competencies, they are the foundation upon which an organization or the culture, the core values, and the strategies are actually built on. So some of those examples, when you talk about like an organization competency, that maybe include like fraud, waste, and abuse, or code of conduct, or conflict of interest. So they impact the whole organization, not just an individual group or department. And then there are the behavioral competencies that you actually want to assess. And these are related to behaviors or attributes like leadership, adaptability, conflict resolution. And then with these type of competencies, they're actually personal and interpersonal skills, and they define how we conduct ourselves in a professional setting. When we talk about behavioral competencies, these are competencies that are adaptable, flexible. So some of those examples would be cultural awareness, age-based diversity, religious diversity. A lot of the DEI competencies that we see that would actually fall under the behavioral competencies, and then emotional intelligence. So again, these are just some of the competencies as an IP that you're going to want to have a very firm understanding of, because you will be required to actually validate those competencies with your staff. Next slide, please. Quiz 4. Did you post quiz 4, Patty? I saw it was up there, but I wasn't sure if they actually used it.
Thanks. Yeah.
Yep, I'm sharing the results, and they have chosen core competencies.
Correct. All right, next slide, please. So when we define competency, to reiterate, and not to confuse with compliance, that's the other thing. So competency, don't confuse with skill, and don't confuse competency with compliance. Competency must be measurable. That's the key word there, measurable, meaning something that can actually be quantified and tracked over time. It is a pattern of knowledge, skills, and abilities and behaviors. So when validating a staff's competency, it's important to remember that a surveyor must determine through information attained by observing and interviewing staff and by reviewing employee records whether the facility employs competent clinical support staff. And how they obtain the information is by the information that's actually collected by you. So going out on the floor, validating, watching your staff perform a skill, and then being able to identify if they're able to perform the skill that meets the expectations of this your policies and the current standards of practice as well as regulations. Staff competencies are necessary to provide the level and types of care needed for each resident and population. Again, it depends on the patient population or resident population that you have in your facility. So they are actually individualized to your resident population and your facilities. And then with competency, education and training competencies involve personal, regardless of their role and position. And so this actually includes managers, director of nursing, nursing home administrators, managers, staff, vendors, volunteers. So really, it doesn't matter what your role is. Every role has a responsibility to have their competencies evaluated on a regular basis. They must be validated and they must be measured. And then with regards to your nursing staff, regarding their licensure, your facility must ensure that licensed nurses have the specific competencies and skill sets necessary to care for residents and their needs. So remember, core competencies equals skills, and that equals proficiency levels. And I say this because I find it, it's not uncommon, I should say, that when talking with facilities, they just have this assumption that a staff member coming, if a nurse can give an injection, don't assume just because a job, a role or responsibility falls under a specific role or title, that individual can actually carry out that skill in a competent manner. We have this assumption that, like safe injections, every nurse can give a shot, they should be able to do it safely, and that's not the case. So again, we want to make sure that we're updating those competencies on a regular basis to make sure that staff can actually carry out those skills and provide the care that your residents need and deserve in a safe manner, and to protect your staff. Next slide, please. So the competency process encompasses the KSAB model, as I mentioned. And so that actually stands for the knowledge, skills, abilities, and behaviors, which combines relevant personal characteristics for an employer to successfully perform the responsibilities of the job. And what that means is when your staff member is carrying out a responsibility, a role, a task that they're assigned to, you just need to make sure that they understand they have the knowledge that they need to perform the skill. They can actually perform the skill based on the education they've been provided. You want to make sure you're evaluating their attitude and then their behaviors. And so when I talk about knowledge, this is actually the practical or theoretical understanding of a subject. So it's your job to make sure that they have a clear understanding what that role, the details of that role, and what it means to actually carry that role out or that task out in an effective manner. So information developed or learned through an experience. It is the practical or theoretical understanding of a subject. So skills and abilities are, as well as personal skills and abilities. The results of repeatedly applying knowledge or ability. So skills, as mentioned, are not the same as competencies. Skills are specific to a learned ability. So again, skills are something that we learn. That is something that is taught to us, and this allows us as individuals to complete a task. Where competency is a combination of all of those, the knowledge and the abilities and the behaviors needed to actually carry out that role and that task. And then the other thing that you want to make sure you're validating is a person's attitude. So a lot of times a person's attitude actually can impact exactly how that skill is carried out. So when you're actually out on the floors and you're validating competency of a skill, one thing that you want to really consider is just kind of stand back and watch, how is their attitude impacting that skill? So what is their feelings? What are their emotions? What does that look like? Because the feelings and emotions, they're natural and they're also learned. And we often see this with staff when we say they're motivated to work harder or do better. Attitude is an important attribute to learning, especially if it's a new skill. I like to say that people fear what we don't know. So if it is a new skill that you are that a staff is actually being asked to carry out, and you notice that there's a change in their attitude, it may not be so much that they have a bad attitude. It may be they're just fearful of demonstrating that skill because they're not comfortable with it yet. So that would be your role to actually identify the root cause to some of those behaviors that you may be seeing. And then in addition to attitudes, attitudes actually drive a staff's behavior. So with behaviors, these are, they're specific to each person. They are observable reactions for a certain situation. So when we talk about competency and learning and education and training, behaviors are patterns of action or conduct. And they actually, again, they are actions that a person actually takes. So they may have an attitude, but it's going to be in their behaviors that actually, it's the attitude that would guide and direct that behavior. So an example regarding behaviors and learning, maybe does a person know how to do something? Do they choose not to do it just because they know how to do it? Are they choosing not to do it? So again, asking those questions when you're validating a competency, you know, why did you do it this way? This questioning, you want to ask those questions, you know, why did you do it this way? Why did you not do it this way? Again, is it behavior related? That's what you want to be able to identify. Next slide, please. And then with competency, you want to make sure that you are performing a hands-on competency assessment. And so when you perform a hands-on competency assessment, and that means actually going out, observing, and just visualizing in real time a skill being performed. So with a competency assessment, you want to make sure that you have a competency check and observation audits. And so when we talk about auditing, a competency check is used, it's like a checklist. You can use a checklist. This is used for staff to demonstrate their ability to perform a task, and it validates their understanding to a structured environment. So you want to make sure when performing a competency check that the employee is aware of the observation. Education and training is provided first, and that's what's most important with competency. You want to make sure that you provide, again, that skill, that education, the training that's needed to know to carry out the task, and then you will follow through with validating. Do they have a clear understanding of that? Other areas that you want to focus on with a competency assessment is observation audits. You want to observe the actual work of the environment. You want to validate ongoing compliance and performance. Observation audits are usually unannounced, and they allow for identifying of process failures. So when we actually work with our facilities, we will have them go out and validate staff's competency. A lot of times when we're looking for baseline data, we often tell them just to do an observation. Don't let your staff know that you're actually watching them. And that will give you a great idea, you know, if your staff is actually meeting competency and compliance. Because a lot of times we know that, and myself in general, you always do what's right when people are watching, but you want to know how are your staff actually performing when they think they're not being watched. So that'll give you a more accurate assessment. You also want to develop and utilize a competency assessment tool or checkoff list for guidance. So when validating a team member's proficiency regarding a specific skill, like some areas like hand hygiene, PPE, injection safety, and oral hygiene, it's just nice to have that checklist to help guide you through that process. Competency should be performed upon hire. I can't tell you how many times I've asked facilities, you know, regarding a specific skill, do you validate staff's competency on hire before they're actually off orientation? And a lot of times, especially skills like antibiotic stewardship, injection safety, it's not uncommon that I hear no. So you want to make sure that you are validating competency upon hire annually, so your annual requirements, and then as needed. So if there is a change in a standard of practice, if there's new education, you want to make sure that after you provide the information and details to and training to your staff that you're validating, they have an understanding of the information that they received. The completion of a competency assessment can be delegated to a qualified individual once the person has been trained in the skill they are assessing. So as an IP, let's just say that you're asked to go out and do hand hygiene audits. You don't necessarily have to be the individual who does the auditing and validating that competency. You just want to make sure that you task that to an individual who is actually qualified, that you know or feel that they would actually follow through and they will do it correctly. You also want to visualize observation of staff demonstrating a skill. This should be, again, announced and unannounced. I encourage both. In order to objectively validate staff's competency involving a skill, it's important that you perform a visual observation. So if it's a skill in a task that is new, I always say make sure that you are actually out there observing that skill. Just don't assume that your staff have a clear understanding what's expected of them. I encourage you to develop a plan for incompetency. So we have plans when our staff are competent. We have a checkoff list. We can put, yes, it's great. They're competent. They can do the skill. And that's fine. And then we just we check the box and that goes into their file. But do you have a plan in the event that a staff member is incompetent in a skill? And so what are you going to do if you witness a task being performed incorrectly, unsafely? So what does that look like for you and for your facility? So you make sure you have a plan. Maybe that includes like a hands-on training, an online resource that may have a pre or post test, a return demonstration, or you may require like a return observation in that teaching moment. And we have multiple resources. So if you ever run into a situation where that you identify that your staff maybe are incompetent regarding a specific skill, please reach out to us because we have like multiple resources that could help you in that process. And then after competency assessment, it's important that both the observer, so if you're the one actually observing your staff, you and then the staff member who was observed, date and sign that competency. And then the results should be kept in your staff's individual file. Next slide, please. And so this is just one of many checkoff lists that we have readily available to you and for you. So when validating a competency, you should, as I stated, use a well-developed tool such as a checkoff list. And so I found like with a checkoff list, especially if you're a newer IP, this actually will help guide you through that whole entire process of actually validating a competency of a skill. And one thing about a checkoff list, it helps that you don't miss any of the key points. So there may be key points that you would just overlook in the moment, but if you're following that checkoff list, you're sure to cover every one of those components that need to be evaluated. I did on the slide, I gave you the link to one of our checkoff lists, but if there is a checkoff list, because I know most facilities have their own, but if you wanted to utilize one of our resources, please let us know and we'll be more than happy to get those to you. I know that when I initiate my own QIIs with my facilities, whatever that QII may be in, I always offer that to them just as an additional resource. As I say, you don't have to use it, but it may be something that you may find more beneficial or find beneficial down the road. So again, this is a checkoff list. I encourage you to use it to guide you through the process of a competency assessment. Next slide, please. And then why are competency assessments important? Again, they help to identify any gaps in your staff skills. So if a gap is identified, you will want to identify the root cause and have a better understanding. Maybe it was the education that was provided. Maybe it was the training that was provided. Maybe it wasn't so much the educator or the person training as it was maybe the understanding of your staff, or maybe it was how it was presented to your staff, that maybe there was a problem with the education and the training, because we all learn differently. So again, you can identify gaps to the training that was provided to your staff. Then once you're able to identify reasons for your gaps, this will only improve future outcomes for your staff and your residents. And then you want to be able to identify strengths and growth. And so you can actually do that through a competency assessment. You're actually visualizing and able to identify what strengths and growths do your staff have, and especially areas that are very prevalent and like need to be assessed on a regular basis in your facility, whether it's hand hygiene, PPE. You can use this for your environmental services, dietary. You can use assessments in any department. Checkoff lists also help to identify priorities and develop goals to improve the delivery of care within your facilities. And then remember, competency improves overall compliance. So if you want overall compliance, you have to make sure your staff are competent. If your staff are not competent in a skill, you will find that you will have poor compliance in your building. So something to remember there. And then it also enhances employee performance. So if a staff member understands their individual strengths and areas for improvement, this in turn leads to enhanced employee performance as well as job satisfaction. So a lot of times you find that staff actually leave their positions because they're not properly trained. They don't know how to do the task. And so either, if they feel like they're in an unsafe environment providing a care or a task or a skill, they're not going to stay. So you want to make sure that they have the proper resources that they need to do their job. They've been properly trained, and then it's up to you to make sure that they have a clear understanding through a competency how to perform that skill. And then finally, a competency assessment guides the development of effective education and training. It helps you to improve your education as well in your facilities. Next slide, please. And then for the infection preventionist role and staff competency, again, your competencies are your skill sets and they must be evaluated. It's important that you understand that the skills that your staff are required to carry out on a daily basis in your facilities must be evaluated. They need to be assessed on hire, as I stated, annually. And then if there's any changes in your policies, procedures, practices, if you have any changes in your technology or introductions of technology, new equipment, or if there's any changes in regulations, you should always be making sure that your staff have an understanding how to perform that task. IPC competency should reflect the expectations desired in the facility's assessment. So with F83A, 838, a facility assessment must address or include staff competencies that are necessary to provide the level and types of care for the resident population. And then the IP should have a plan how staff will be evaluated to determine if they are demonstrating knowledge according to your current standards of practice in your building. Next slide, please. And then the effective training education results in competency, which equates to compliance. So when we talk about compliance, it starts with proper training and it's a systematic approach. And this is kind of a diagram that I frequently use. Competency-based training has emerged as a best practice, especially when you are ensuring sustained compliance readiness for your building. So how I best describe it is compliance training should be initiated from the get-go, meaning from your onboarding process to regularly scheduled education over the course of the year. I do recommend your facilities create an annual education calendar. I often will provide that to my facility. So I provide a calendar, and then every 3 months you're providing some form of education covering specific topics. And I try to, in those calendars, incorporate all departments for all different skills and tasks, meaning I may have some clinical education, environmental education, but as long as you're providing education every 3 months, you're guaranteed to actually meet those requirements that you need for your annual requirements. And then this calendar also allows time for you to communicate and prepare for your staff for upcoming training. And this will also help prevent any missing in any required annual trainings that you may need to complete, especially for surveys. And then I'm going to turn it over to Jess.
Thanks, Amy. So we're going to move into FTAG 945 and talk about what specifically is required for education in your infection control plans. Next slide, please. And we have a quick poll question. How often should staff education be provided and competency be validated?
Looks like they are coming in fast and furious with choice A.
Yes. So when we look at the regulation, our guidance lets us know that all the facilities must develop, implement, and permanently maintain an effective training program for all staff. This includes training on standards, policies, and procedures for the infection prevention and control plan that is appropriate and effective as determined by staff need. Next slide. So who are our staff? Well, when we look around our building, we've got our direct and indirect care staff, but we also have our contracted staff, our agency and travel contingent staff. Pharmacy may be a contracted service, therapy may be a contracted service. And so we have to make sure they're also educated on following infection prevention requirements. We also have to have a program for educating our volunteers. It also lets us know that we have to have effective educational programs. Well, how do you make them effective? One of the main points is explaining the objectives and generating that environment of teamwork to gain some excitement and momentum around infection prevention and control. It can be pretty dry, but making sure that people really understand the why of what you're doing is important. Another important factor is modeling the behavior that you are teaching. It's not helpful for nursing leadership to be telling the staff one thing and not doing what they need to be doing. Offer training with alternative shifts and schedules in mind. And this can be particularly difficult for those on third shift. We're not expecting day shift to come in the middle of the night, and with third shift, that's kind of what we ask them to do a lot of times. So we need to figure out how we can get them the same education, but not disrupt their wake sleep schedule. Use a variety of methods. There's written, there's video, in-person, hands-on, role-playing, training or tabletop exercises. You also need to consider the language and reading barriers that your staff may have. If you have a low literacy rate, or if you're in an area where you have staff with English as their second language, they may not understand everything in the way that you need them to understand. So making sure that you're looking at what languages and how to educate people that may have low literacy rates. Adapting to backgrounds and learning styles, and then validating understanding. That's the most important part, is validating that they're catching what you're trying to teach them. Provide those opportunities for questions and concerns, get the feedback to make sure you're meeting learning objectives and to develop your future education content. So the DON is actually the one in charge of validating competencies. However, as infection preventionists, I'm guessing that that is delegated to you for infection prevention and control. So this really needs to be a team effort. Review the content that you're going to have for onboarding, and then spot check that that orientation checklist is getting completed and signed off. Establish a process for your annual competency validation. Know what, how, when, and who you're going to train. Like Amy says, make sure you're looking at a calendar. Are you going to offer online? Are you going to do observations? And then making sure that all of your staff, even the people that are PRN, are completing those trainings. So the minimum requirements for staff training noted are preventing the spread of communicable disease. So our staff have to know how to identify and report communicable disease. And then there's the occupational health piece. They have to know when not to come to work when they're ill, and what they should do if they have an exposure to a communicable disease. We need to make sure that they know how to use standard and transmission-based precautions. We need to highlight hand hygiene, cleaning and disinfection, and PPE donning and doffing. And they need to know those policies that involve infection control when they're actually taking care of residents. So again, we're training staff upon hire annually with a policy, procedure, supply, or equipment change, because they need to know how to respond to the changes. If there's a new health risk like the COVID-19 pandemic, if there's an infectious outbreak, a GI or a respiratory outbreak, or if you have bed bugs or scabies, those are good teaching and audit points. You're always going to have that just-in-time training when you're doing observations and you see something that's not done correctly. And if you're seeing widespread knowledge gap or behavior gap, then that's a time for education. That might be your staff isn't wearing their face mask correctly, and getting to the root cause of that and fixing that problem. So kind of looking back, Amy was very detailed on skill, competency, and compliance, but skill again is learning a task and using a skills checklist. Competency is skills, knowledge, abilities, and behaviors guiding to successful performance. So they know how to do it. They can pass the test. They pass the observations. They can teach you back. Compliance is, are they doing what they're supposed to do when they're supposed to do it? Are they following those rules, regulations, policies, and procedures when you're not watching them? So just for an example, we're going to look at hand hygiene. A skill checklist might help us know if they're able to do the task of washing their hands using soap and water and alcohol-based hand rub. Competency might be a test question about when to use soap and water versus the hand sanitizer. Compliance is you're auditing a patient with a C. diff infection, and are the staff using soap and water when they should be using soap and water? These are items you want to document, and then use that information to celebrate with your team, to re-educate when you need to. And if re-education is successful over multiple tries, then it may need to get to the level of discipline, because it's very important that staff is taking infection control seriously. So things to include in your annual training: hand hygiene, outbreak management, transmission-based precautions, enhanced barrier precautions, PPE, respiratory etiquette, disinfection of reusable medical equipment, shared medical equipment, antibiotic stewardship, your occupational health topics of tuberculosis, bloodborne pathogens, injection safety, the illness policies and procedures staff should follow, and the immunizations for staff and residents. These can be informal meetings, just-in-time education in your huddles, or just informally when you're doing audits, or when non-compliance is noted, or when there's a misunderstanding in what staff are supposed to be doing. Other areas identified by your facility assessment. If you know there's a weakness, add it to your training program. But some of those higher risk areas, you may need more frequent education and monitoring, like wound care, peri-care, cleaning of shared equipment, your shower room. We see reports from on-site visits, and the shower room is often targeted for many infection control citations. How you're handling infections and infectious outbreaks with your staff and residents. Cleaning of your glucometers and keeping glucometers to one per person, how catheter care and how peri-care is done. You're also going to want to train your staff to teach and model infection control, not only to each other, but to your residents and your visitors. You also do have to educate your residents, families, and visitors. They need to know how to wash their hands. They need to know about PPE donning and doffing if their loved one is on transmission-based precautions. We need to make sure that we have supplies readily available for them. They need to know cough etiquette and when not to visit. They need to know about your antibiotic stewardship program and your methods of success for that. How often do we start education for residents, families, and visitors? Well, admission is when we start. We also need to do annual education. We need to educate during change of condition for individual residents, for enhanced barrier precautions, for transmission-based precautions. When we do have those infectious outbreaks, and if there is a new health risk. We've got resident council, family councils, some do email blasts, some do one-on-one calls, but whatever method you choose, make sure that you're including them in your infection prevention and control education program. And realize that education is a team effort and should be developed as a team. It's going to be based on your risk assessments and the facility assessment, in addition to the regulation and the requirements. Know where training is required for some people and not others. You are probably not going to train your business office staff to do peri-care, but they are going to need to know how to do hand hygiene. They're going to need cough etiquette. They're going to need to know the occupational health, when not to come to work, what they should do if they're ill. Use your managers as subject matter experts and share the load in providing education and evaluating competency and compliance. As an infection preventionist, you're only one person and you can't be everywhere all the time. So you need to enlist those champions in helping you. Review that education plan routinely and update as required. So you're going to want to do it at least annually, but you're going to want to review it every time you have a new supply or equipment or there's a change in your policies. Make sure that you're offering sessions to all types of shifts and styles of learners, and do your best to find ways to make it fun. So I think we're going to go through a couple more slides here, and then Jana's going to reopen our conversation from last week about antibiotic stewardship and leadership's role and how to handle some of those hard topics and conversations.
Thanks, Jessica. Patty,
All right.
I'm going to take over, and I'm
All
going
right.
to share my screen. All right, you should be seeing my screen, and this is where we left off last week. And we really want to talk about, I'm just going to go through these briefly, but the role of the facility administrator, director of nursing when it comes to infection prevention. If you are an IP and you're a floor nurse, unit manager, assistant director of nursing, maybe you're the director of nursing, but what really is the role of leadership when it comes to this thing called infection control? So when we talk about infection control and their role, one of the first things that I want to talk about is having conversations. And this is the role of leadership when it comes to your antibiotic stewardship program. I think leadership plays many roles across the infection control spectrum, yet really they're the ones that are responsible for making sure that your IP program is successful. But when it comes to antibiotic stewardship, their role probably is a little bit bigger in the fact that they need to understand what antibiotic stewardship is, because they're going to be the one, probably your administrator, DON, speaking with your providers, with your medical director, your physicians, your nurse practitioners, those extenders, talking about their their prescribing habits and their prescribing behaviors, and using your pharmaceutical data, so the data from your pharmacy and from their ordering, to really have those conversations. And sometimes those conversations, rarely are those conversations easy conversations, okay? Uh, we know that physicians and, we get into habits, and you will have families that will, demand the use of an antibiotic perhaps for mom, because when mom gets a certain way, we know it's a UTI, and we know it's a UTI, even though we don't know that it's a UTI, if that makes any sense. And physicians will often order antibiotics based on a family's request or a resident's request without really looking at the McGear or Lopes criteria. Utilizing those criteria is utilizing an antibiotic timeout. So how do you, as an IP, a director of nursing, or an administrator, have those conversations? So first, I encourage you to think about it proactively. So educating residents and families on admission. Do you include in your admission packet to new residents, to their families, primarily the decision makers, daughters, grandchildren, sons, spouses, about your practices for antibiotics and why antibiotic stewardship is important and what superbugs are? And I would encourage you to go out to the CDC website and look at antibiotic stewardship. Just click into that in their website. There are a ton of resources that you can download for free, posters, handouts that you could include in your admission packet to give to families. I also would encourage you to consider giving your policy on antibiotic stewardship, policy on antibiotic usage, like how do you respond? What do you do? So that families know right from the get-go, hey, this is what the process is for antibiotic usage in this location, and this is what you can expect if your loved one is being assessed for potentially having an infection, and these are the steps that we're going to take. So great to start that with families right at the get-go. And then hired for nurses and your providers. If you're bringing a new physician or physician extender into your building, I would strongly encourage you to have that conversation at the beginning before they start working in your facility. And then also think about who is going to be their on-call and their backup. And do those individuals understand and have knowledge of what your practices are, what your expectations are around antibiotic stewardship? And then give them the feedback. Communicate with the providers on their usage. Use the data to tell your story. So again, here's some ideas about educating residents. A resident council, doing antibiotic bingo, doing some kind of activity with residents where you talk about superbugs, you talk about MDROs, you talk about the prevention of them. I think it's really important your residents can understand that. And I think sharing with them that, why, the why behind we do the things that we do. For staff, the same thing. Your staff, do they understand the overuse of antibiotics? A lot of your staff are young parents or parents with littles at home, and littles get things like ear infections and colds and viruses that often parents assume. I was a child of the 70s. I'm old, but I was a child of the 70s, and antibiotics were the super drug. And I remember as a child being given amoxicillin, all of the different drugs that you could be given for potentially viruses. So really helping to explain to young families why and why not antibiotics should and should not be used, and what to do in lieu of, and how to help your kiddo, and how to determine if it's an infection or not an infection, so that they understand too how to prevent those superbugs and what the outcome is when we do get those MDROs. And then high-level audits. I would encourage you to look at your audits. Again, this is that data. Look at your data for your weekends, when your antibiotics are ordered, and use that data to tell the story back to the physician. Look at your patterns, look at your trends. Is it particular staff? Is it particular physicians or practitioners? And how do you, do education or address that? And part of that comes from a difficult conversation. And I hate the word difficult because I think that means it's a challenge or it's hard. And we tend to avoid the really, really hard things, and interpersonal conversations that are hard. I don't know anybody that really enjoys them. And I'm a social worker by background, and even I don't enjoy them. So I will share that with you. But when you're getting ready to have that conversation with a practitioner or with a provider, I think it's really important for you to take the step to just sit down and think about what is it that you need them to understand. Write down your goal. What is the goal of this conversation? And then write down some key points and be prepared to listen. I think one of the biggest challenges that we have when we have difficult conversations is that we do a lot of talking at people, but we don't do a lot of good listening back. And I think it goes both ways. And if you're the one relaying the information that might be hard and might be a little icky to have to present to a provider, like, hey, Dr. Dr. Smith, you are responsible for 95% of all the antibiotics that were used in our building over the last 3 months. And what would you like to do about that? That's probably not the best way to approach that position, but I would suggest that you maybe role play it, maybe talk about it. If it's your medical director, this is a conversation that really you need to have your administrator and director of nursing be part of, and they really need to take the lead because quite honestly, medical directors and practitioners are practicing in your business, in your home, and they're caring for your residents. And if they're providing antibiotics in an unnecessary manner or in an overuse of antibiotics, they could potentially be causing harm at some point to your facility, either through the form of unnecessary medication F-tags. I don't know anybody that's ever gotten an unnecessary antibiotic F-tag. I think all of us sitting here have seen those F-tags and experienced those F-tags. So I think it's really good to just sit down, talk to your leadership, develop those talking points and the points in like delineate it out, like just write down. Practice that active listening, just listen, and then provide education and agree to follow up with them post-conversation. It's okay to agree to disagree, but you've opened the conversation and you've made them aware that, hey, we're collecting data and here's the data that we're collecting. And this is what the data is telling us. And we would like to do a process improvement on antibiotic usage. And we'd like you to be involved in that process improvement. Are you willing to do that? If you need help role playing, I encourage you to reach out. We can help you with that. If you need help developing those documentation points, like what kind of data should you be utilizing, I would look at your ordering and prescription habits. I would look at the types of infections that you have in your building, your MDRO. Are you growing superbugs in your building? And what's going on, within your hospital system or in your environment around your facility? What else is being experienced? And then talk to your peers. Like, most medical directors don't operate in a vacuum. They often provide care for multiple facilities and in regions. And if this is an area, maybe that's a way to look at it and talk about it. So I'm going to open up for questions because I bet we have questions, Jessica. If anything coming in the chat.
We did have a question in the chat on, do we have suggestions on how to communicate with the physician that has ordered an unnecessary antibiotic without clear indication and without an end date?
Boy, without an end date. So first, if it's your medical director, I'd enlist the conversation with your administrator and your director of nursing, and I would ask them why. I would do it politely, but say, hey, Dr. Smith, I see that you ordered, Mary Sue this antibiotic, and I noticed that when we took the order, we forgot to, we didn't get an end date. Would you like to give us an end date for the antibiotic? And could you give us the criteria for the antibiotic so that we can document that? And if they're like, no, I don't intend to give an end date. Okay. So help me understand, walk me through the decision-making process for the use of this antibiotic so that I can better learn from you why we're using this antibiotic in what manner, because I'm trying to figure this out and we need to do documentation for this resident and we need to address it because it looks like, and it potentially looks like an unnecessary med. And I don't know, this is a tough one. Nurses, you guys got to help me out with this one because as an administrator, I would tell you I would have those conversations with physicians and they would say, well, 9 times out of 10, it was because the family demanded it, is what I would hear. The family demanded that we give this medication because that's what the patient responds to. Or I've treated this resident for, this patient for 35 years out in the community, and this is what happens, and this is why I give them that antibiotic. Patty, Jess, any thoughts on that? Amy?
So yeah, after you've had the conversation and if you feel like you're not getting anywhere, a lot of times I've enlisted the pharmacy to complete a drug regimen review because sometimes the pharmacy can come at it from a different angle and they'll write a piece of paper that says we need a diagnosis and an end date for this antibiotic. And then that may just prompt the provider to say, I don't know, we're going to DC it. They don't want to mess with those any more than they have to.
Yeah. We just
but
had a comment come in that they recently had a situation, prescriber non-responsive, finally had to elicit the help of the medical director. Absolutely. Your medical director is the most important person in this conversation. And if your medical director is the one writing those orders over and over again for antibiotics, that's the conversation you need to have with your administrator or other powers that be that hire your medical director, because those are generally employees of the organization and they need to follow the policies. They sign off on the policies. I mean, they should be reviewing the antibiotic policy as part of your annual policy review. So they know very clearly, they should know what the policy is, right? Of the facility. Again, education is critical. A lot of times your on-call docs are hospitalists that really don't understand how nursing homes operate and the rules and regs that we operate in. So education can be your best friend. Giving them copies of the FTAG, having physician meetings, even if it's once or twice a year where you pull all your docs in, you provide them with a meal, and then you do an education and involve the pharmacy, Jessica, right? Because the pharmacy sends those recs out to the medical director and to the physicians. They should be sending physician feedback. Usually that's a monthly thing where the physicians get a stack of pharmacy recs and the docs have to go through them. And if I'm a doctor and I'm getting 50 pharmacy recs because of my antibiotic usage, you as the facility should be QAing that and it should be going into your coffee so that your medical director sees, here's all the different, here's 5 medical providers and here's their ordering practices. And this one's really an outlier. So doc, medical director, can you address it with this provider? But just having those conversations it's just like hand hygiene. It's over and over and over again, and frequent education, frequent discussion, and practice. I think role playing those conversations and writing it out, like what it is, the key points that you want to cover, I think are critical to keeping the conversation on track. And we're over time. Is there any other questions that anybody has?
I did throw a link to our event evaluation at the chat. If everybody could take a minute to evaluate our presentation today, give us feedback. We like to make it useful and better for all of you.
And we will see you all next week for our last week. So thank you all. Have a great rest of your week.
Yeah.
Bye-bye.
Bye.